Hello, and welcome to the topic Fluids, Electrolytes, and Acid-Base Balance. This is Unit 2 of Medical Surgical Nursing. Just as a disclaimer, this recorded lecture is intended for Level 3 students of the Bachelor of Science in Nursing program. This material is based on the textbook Hinkle and Shiver, Brunner's and Sudar's textbook of Medical Surgical Nursing. This lecture does not constitute medical advice, and part of the discussion may not be suitable for the general public. This is only a supplementary material and is to be augmented by live or synchronous sessions to reinforce understanding of the concepts. If there is any, the views expressed in this presentation are my own and do not represent the opinions of any entity whatsoever with which I have been, am now, and will be affiliated. The photograph and videos used in this presentation belong to the respective authors and websites. No copyright infringement is intended. If you have any concerns with this presentation, it may be sent to the email indicated on this slide. Once again, good morning, good afternoon, good evening, dear students. This is Fluids and Electrolytes, along with acid-base imbalances, among the most interesting chapters in medical surgical nursing. For this unit, the focus of our discussions will be the following: physiology of fluid and electrolyte balance, fluid volume deficit, fluid volume excess, electrolyte imbalances, particularly sodium, potassium, calcium, and the very interesting acid-base imbalances. Why? Why is it important for us to learn these concepts? The first thing that we need to understand is homeostasis. When I say homeostasis, homeostasis stands for a state of internal equilibrium. Again, it is the state of internal equilibrium, which is brought about by positive and negative feedback mechanisms. Among the very important things that happen in our body that maintains homeostasis is what you call your fluid and electrolyte balance. Any problem with the fluid and electrolyte may result to significant alterations in one's body system. Why? 60% of our body is composed of fluids. There are different factors that influence the amount of body fluid. One is age. If I would compare a young patient to an old patient, a younger patient have more water content compared to an older patient. This means that elderly patients are at high risk for dehydration. Furthermore, the extreme of ages are also at high risk for fluid volume deficit. This would include patients who are very young, such as your infant. Gender. Between male and female patients, it is the female patients who have less water compared to their male counterparts. This is because of the rich adipose tissues among females. Body fat. Body fat is also your adipose tissue. Generally, patients who have more body fat have less water. Take note that body fat and water do not go hand in hand. If you can notice, you cannot easily mix fats with water. That's why the more the fat, the lesser the water. Skeleton also tends to have low water content. On the other hand, muscles, skin, and blood contains the highest amount of water. Take note of these things. So again, those who have minimal water are the elder patients, the female patients, and then your obese patients who have several adipose tissues. Other than that, we need to know that the 60% of the body fluid that we have is divided into two major compartments, commonly referred to as your intracellular and then extracellular water. Almost two-thirds of the body water or the body's water is in the intracellular space. As the term implies intracellular, this is within the cell. So, if I would be looking at the percentage, this is 40% of the body weight. It is commonly referred to as the most stable compartment, which are fairly resistant to major fluid shift. Approximately again, two-thirds of your fluids are in the ICF compartment and are located primarily in your skeletal muscle mass, your intracellular fluid space. Next, extracellular water. When I say extracellular water, as the term implies, the water is outside the cell. This is 20% of the total body weight. Here in our case, it is divided into three parts or three components. You have interstitial, plasma, and then transcellular. Let's go first to interstitial. When I say interstitial, these are fluids that can be found surrounding the cell. It is approximately 10 to 12 liters among adults. Common example of your interstitial fluid are your lymph fluids. Plasma. Your plasma, also known as your intravascular space, is found within the blood vessels. So again, it is found within the blood vessels. That's why your plasma is also referred to as intravascular body fluid. When I say class intravascular, meaning it can be found within the blood vessels. So that's your plasma, the liquid component of your blood. Next, you have your transcellular space. Your transcellular space is considered to be the smallest division in your ECF. As shown on the diagram, this would only have 1% of the total 60% of body water. Examples of this are your cerebrospinal fluid, which can be found in your central nervous system. Other than that, you have your pericardial sac, which is the sac that surrounds your heart. Other than that, you also have your synovial fluid, which can be found in our joints. You also have your intraocular fluid. Your intraocular fluid, intraocular, can be found in your eyes. You also have your pleural fluid. Your pleural fluid is the fluid that surrounds our lungs. And then you have your sweat and then your digestive secretion. So that is your transcellular space. Again, you have two major spaces. You have the intracellular space and the extracellular space. Majority can be found in the intracellular space, which is considered to be the most stable. On the other hand, 20% can be found in the extracellular space. In the extracellular space, you have interstitial, intravascular or your plasma, and then transcellular. Third spacing. When we are talking about fluids, one important concept is third spacing. Third spacing is commonly referred to as the fluids in the wrong spaces. So when I say class third spacing, it is the loss of extracellular fluid that does not contribute to equilibrium. What is one major characteristic of your third spacing? Your third spacing is characterized by a decrease of urine output despite adequate fluid intake. Again, it is characterized by decreased urine output despite adequate fluid intake. Why? What happens? This is referred to class as third spacing because the fluids are not staying in the places where they should be. For example, you have your intracellular and then you have your intravascular spaces where you expect the fluids to be. But in third spacing, these fluids shift to your transcellular spaces. It shifts to other spaces, such as your abdominal cavity or your peritoneum. One example of your third spacing is ascites. Okay? Fluids in the wrong spaces. Meaning, the fluids in your blood vessels, in your cells, are being shifted towards the peritoneum, leading to ascites. Another example of your third spacing is pleural effusion. When I say class pleural effusion, recall that pleura can be found surrounding your lungs. The fluid that surrounds your lungs. There is a normal amount of fluid that surrounds our lungs. However, in third spacing, due to increased permeability, much of the fluid are transferring to our pleural cavity. That's why there is what you call pleural effusion. Signs and symptoms would also include signs of intravascular fluid volume deficit. Hence, your heart rate will be affected, it will be increased, the blood pressure will be decreased, the CVP will also be decreased. Again, it would manifest as signs of intravascular fluid volume deficit. Do not be confused. I'm thinking of a patient with ascites. So, an ascites patient is somebody whom you think would have fluid volume excess because there are fluids in the wrong spaces. However, their signs and symptoms class would manifest as fluid volume deficit, intravascular fluid volume deficit, because your patient is having the fluids, but the fluids is not again in the right spaces. Because of this, heart rate would initially increase. Blood pressure would be decreased. And as what we have discussed, central venous pressure is talking about the amount of fluid okay, or the amount of pressure in your right atrium. So if there is fluid volume deficit in the intravascular space, your CVP would also be decreased. Edema could be there. Weight. For weight, we are exploring the possibility of weight increase. An increase of 1 kilogram is equivalent to 1 liter of fluids that is being stored inside our patient's body. And then you would notice an imbalance in the intake and output. You might notice that, for example, your patient would initially have an intake of 3 liters, and then later on it would turn out that their output is 2 liters. Meaning your patient, other than the insensible losses, is storing water within the wrong spaces. Okay? Those are things that might be considered. The next concept that we have are your electrolytes. When I talk about electrolytes, these are active chemicals that are present in our body. There are different kinds of electrolytes. When I say cations, these are positively charged electrolytes. Just remember they're cat, letter T, that's positive. The most common cations that we have are sodium, potassium, calcium, magnesium, and hydrogen ions. Anions are negatively charged electrons. Now you have there your chlorine, you have your bicarbonate, you have your phosphate, sulfate, and even your proteinate. Your electrolyte concentration class is measured in terms of milliequivalents. And when I say milliequivalents, this is a measure of chemical activity. Now, there are different kinds of electrolytes that would prevail in the intracellular space and then the extracellular fluid compartment. Class, when I say intracellular space, it is usually potassium. Okay? It is potassium that dominates, or what we call to be the dominant electrolyte in your intracellular space. On the other hand, your ECF is considered to be the dominant electrolyte or the major electrolyte in your extracellular fluid compartment. As I have mentioned, class, the major ECF electrolyte is your sodium. The major ICF electrolyte is potassium. Despite this, class, you need to remember that the amount of electrolytes that we are measuring are the blood plasma levels, or meaning the amount of electrolyte outside the cell. Do not think that because potassium is an ICF electrolyte, we will be measuring the amount of the electrolyte inside the cell. We are only measuring the amount of electrolyte outside the cell. That's why we commonly refer to it as serum, sodium, and then we commonly refer to it as serum, potassium, when we are referring to our laboratory test. This means, class, that we are measuring their levels in the serum. Special techniques will be needed to measure their components, to measure their concentration in the ICF. So take note, sodium is an important electrolyte. When I talk about sodium, class, it affects the overall concentration even of your extracellular fluid space. It is important for the regulation of your body fluids. The common dictum that we have is whenever sodium goes, okay, water goes. So that's why your sodium is also relevant in fluid retention. Okay, decreased amount of body fluid may also lead to hypernatremia or your excess of sodium. We'll have more on that later on. Then your potassium is considered to be the major electrolyte in the ICF. There is a low concentration of potassium in the ECF. That's why a decrease in the potassium levels in the ECF could mean significant effects on the cardiac status of the patient because there are only minimal amount of potassium in our serum. Now, you might be wondering, since potassium is inside the cell, when can large stores of potassium be released? Just think, it's inside the cell, meaning damage to the cell can result to large stores of potassium being released. When is this damage occurring? That may be because of trauma, that may be because of burns, that may be because of excessive trauma to our cells. Okay? So once there is trauma to our cells, let's say for example, a very tight tourniquet is applied to your patient. The tight tourniquet could cause lysis. And because of this lysis, potassium within the cell would be released. Hence, your patient might have pseudo-hyperkalemia. Now, there is a term cell membrane pump. When I talk about cell membrane pump, you think about the sodium-potassium pump that you have discussed in anatomy and biochemistry. So it is your sodium-potassium pump that takes note or takes charge of the exchange of sodium and potassium ions. Because remember, I mentioned potassium is rich in the ICF, sodium is rich in the ECF. So, for this exchange to take place of the sodium-potassium and for them to do their job properly, there needs to be an entrance and exit from the cell. And that is maintained by your sodium-potassium pump. You have the two terms there, hydrostatic pressure and osmotic pressure. These two pressures are the one that takes charge, with the normal movement of body fluids in your capillary. So class, when I talk about your capillary, take note that your capillaries are your small blood vessels. So when I say hydrostatic pressure, class, it is the pressure exerted by the fluid on the walls of your blood vessels. So again, pressure on the walls of the blood vessels. So class, there is a specific pressure here that allows fluid to stay or escape within the blood vessel. Osmotic pressure, on the other hand, class, is exerted by the protein of the plasma. Take note, osmotic pressure is exerted by the protein of the plasma. When I talk about protein, class, you have your serum albumin and then your serum globulin. Between the two, the more dominant one is albumin. And if you can recall, the rich source of albumin among the food that we take is your egg white. Okay, egg white is among the richest source of albumin. That's why, class, in the hospital setting, you might have noticed that patients with edema, fluid volume excess, or third spacing fluid shift are usually managed with egg white in the diet. Or usually they would have your albumin transfusion, because decrease of the albumin would lead to decrease of the osmotic pressure. So what happens if there is a decrease of osmotic pressure? The fluid will escape the intravascular space. If the fluid will escape the intravascular space, it would go to your extracellular, transcellular spaces. If it will go to your transcellular spaces or extracellular spaces, you have your problem, which is your third spacing. Now, let's talk about the regulation of body fluid compartment. Let's talk about the term osmosis and osmolality. When I say class osmosis, osmosis is the movement from the region of low solute concentration to a region of high solute concentration. Keyword that you need to remember is movement, low to high. Okay, low to high. The term tonicity, class, corresponds to the ability of all solutes to cause osmosis. And these, okay, solutes that can cause osmosis are referred to as osmoles. They are capable of affecting water movement. Examples of these are sodium, mannitol, glucose, and sorbitol. This slide shows the difference between osmosis and diffusion. As mentioned, osmosis is the movement from an area of low solute concentration to an area with high solute concentration. As you can notice, it further explains that the movement is from the area of low solute concentration with high fluid concentration to an area of high solute concentration and low fluid concentration. And look at the result. There is a transfer of fluids from these two areas. Okay, if you would look at diffusion, diffusion is the movement from an area of high solute concentration to an area of low solute concentration, which allows for the even distribution of solute and solvent towards the two compartments. We also have the term oncotic pressure. Oncotic pressure is the pressure exerted by the protein. And one example that we have is your albumin. Another term is osmotic diuresis. When I say diuresis, that is about excreting your urine. Okay? Hence, osmotic diuresis is the increase in your urine output, which is caused by the excretion of your substances, such as your glucose, your mannitol, and your contrast agents in the urine. On the other hand, diffusion, as previously defined, is the movement from higher concentration to lower concentration. Examples of this is the exchange of your oxygen and carbon dioxide. Another example is the movement of your sodium from the extracellular fluid compartment to the intracellular fluid compartment. Filtration. Your filtration is the movement from an area of high hydrostatic pressure to an area of low hydrostatic pressure. Your filtration could be best observed in your kidneys. Remember, our kidneys filter 180 liters of plasma per day. Okay, as I've mentioned, filters. So the process that takes place there is filtration. Then we have your term sodium-potassium pump. Your sodium-potassium pump is the one that actively moves sodium from the cell into the ECF. In this case, class, active transport is being utilized. And when I say active transport, it means energy is being used for the movement to occur against the concentration agent. So this is your sodium-potassium exchange pump. Now, there are different kinds of routes of gains and losses. This table summarizes the intake and output that we may encounter for our patients. So one, oral intake may be, for example, up to 1 liter. Food intake may be up to 1.3. Water or oxidation is at 200 ml. Okay, this is just an example, class. Look at the output. Urine output is at 1.5. Stool is at 200. And then you have insensible losses, which includes your lungs and your skin. If you can experience in the hospital setting, it's very rare for you to encounter that a patient would have an intake of 2,500 and then an output also of 2,500. Although this table shows how intake and output may be equivalent, in your setting, when you are recording the measurement of the intake and output of your patient, you cannot measure the insensible losses. That's why commonly you can see a difference of 500 to 800 between the intake and the output. And that might not be considered abnormal depending on your case of your patient. Why? Again, these are insensible fluid losses which cannot be documented. Come to think of it, can we even measure the amount of sweat of our patients? Obviously, we cannot. That's why usually intake is higher than the output. Now, your kidney. The kidney plays a major role in our fluid and electrolyte balance. Usually, the daily urine volume that a normal adult would have is 1 to 2 ml. As a general rule, class, approximately 1 ml of urine per kilogram of body weight per hour is what is expected from an adult. Skin. Your skin is responsible for sensible perspiration. Okay, this includes visible fluids and electrolyte loss through the skin, which is done by your sweating. Take note, class, that in a sweating process, there are major electrolytes that comes with your sweats, and these include your sodium, potassium, and chlorine. Your sweat losses, class, or your sweat losses, would include 0 to 1,000 ml or more every hour. Okay, insensible losses, which are non-visible forms of water losses, are increased, especially in times of having fever, exercises, and loss of natural barriers. What do I mean by natural barriers, class? The natural barrier that we have is your skin. Whenever there is loss of the skin, class, there will be an increase on the insensible water loss. Particular example of a case with lost skin is, of course, your burns. Okay, if there is a lot of area of burn, or if the TBSA, total body surface area of burn, is very high, class, insensible water losses is more likely to occur. Lungs. The lungs eliminate water vapor, which is also considered to be an insensible loss, approximately 300 ml every day. Take note, class, that the loss or insensible loss through your lungs is increased if you are having increased respiratory rate, depth, and of course in your dry climate. Other than that, you have your gastrointestinal tract. Usually, there will be a fluid loss of 100 to 200 ml. That's the normal. Okay, that is expected. Now, the bulk of fluid is normally reabsorbed in the small intestine. That's why if your patient would have diarrhea, your patient would have fistula, Okay, this would cause large losses of fluids for our patients because absorption of your fluids take place in your intestines. It is almost the 25th minute of this lecture. It is advisable that you pause this video. You can give yourself a 5 to 10 minute break. Let's talk about the laboratory test for evaluating fluid status. The first laboratory that we have here is osmolality. Osmolality measures solute concentration per kilogram in blood and urine. So class, usually if it is blood, it is referred to as serum osmolality. If it is urine, of course, urine osmolality. Remember that osmolality is the solution's ability to create osmotic pressure. Highlight osmotic pressure. That's why it's referred to as osmolality. Now, the serum osmolality reflects the concentration of your sodium, blood urea nitrogen, and glucose. That's why, class, if there is a need to estimate the amount of your osmolality without having the test, the quick estimate could be done by having the sodium, blood urea nitrogen or BUN value, and then glucose. The normal osmolality of our serum is 275 to 290 milliosmol per kilogram. Again, the normal value is 275 to 290 milliosmol per kilogram. Now, urine osmolality, on the other hand, would measure the concentration of your urea, creatinine, and uric acid. When measured with serum osmolality, class, your urine osmolality is considered to be the most reliable indicator of your urine concentration. Later on, you will see tests such as urine-specific gravity, examination of the color of the urine. Among all of them, class, the most reliable indicator of your urine concentration is your urine osmolality. This table is a comparison of the amount of serum osmolality and urine osmolality and the factors which leads to its increase. This can be found in your textbook. Let's try to tackle some items. You can notice that serum osmolality would increase in case of dehydration. Okay? Why? Take note, class, that serum osmolality is the measurement of concentration. Once fluid is decreased, it means that the solution becomes highly concentrated. So in this case, in dehydration, osmolality is expected to increase. Free water loss is an example also. Another example is diabetes insipidus. If I'm talking about diabetes insipidus, just recall that it has two P's. If your diabetes mellitus has 3 P's, your diabetes insipidus has only 2 P's. And these 2 P's would be polyuria and polydipsia. When I say, class, diabetes insipidus, your patient are characterized or your patient is characterized by continuous urinating and urinating. Okay? Even if you will hold the water intake of your patient, they will continuously urinate. That's why, class, there is decrease of body fluid, there is decrease of body water, leading to increased osmolality of the serum. But come to look at this. Okay? Serum osmolality is increased, but urine osmolality becomes decreased. If you would remember the physiology that I've mentioned to you, okay, in diabetes insipidus, there is continuous urinating. If there is continuous urination on the part of your patient, what do you think happens to the urine? Is the urine diluted or concentrated? Because of that continuous urination, the urine will become diluted. And because of that dilution of the urine, class, your urine osmolality is decreased in your diabetes insipidus. Okay, take note of that. Then you have your hypernatremia. Your hypernatremia also increases your serum osmolality. Other factors are listed here. For your decreasing factors, okay, you have fluid volume excess, syndrome of inappropriate anti-diuretic hormone. Think, anti-diuretic hormone. When I say anti-diuretic hormone, class, what does it do to the urine? Does it hold water or does it excrete urine? It says anti-diuretic. It's anti-diuresis, meaning It stops one, okay, it stops one from urinating, meaning water is retained. If there is retention of water, class, the tendency is that there will be more water compared to the solutes. That's why there will be decrease on the concentration. There will be decrease on osmolality. Then you have other diseases listed there. As you can see, for the syndrome of inappropriate anti-diuretic hormone, the urine osmolality would now be decreased because there is anti-diuretic hormone, meaning the fluids are not getting out. Okay, the urine becomes decrease or increase. The urine output becomes decrease. And since it is decreased, it has a tendency to be more concentrated. That's why serum osmolality would be increased. Okay, take note of some of these examples. Then, osmolarity. Osmolarity is the concentration of your solutions, okay, which can be or usually within 10 milliosmoles of that of the value of osmolality. So if the normal value for your osmolality is playing at 275 to 290 milliosmol per kilogram, your osmolarity class is playing at up to 300 milliosmoles per kilogram. Okay, take note of that. Then you have your urine-specific gravity. For your urine-specific gravity class, the normal value is 1.010 to 1.025. Just take note, class, that if the value is increased, this means that the urine is highly concentrated. Just like your osmolality class. If the value is increased, meaning the serum or the urine osmolality is concentrated. For your urine-specific gravity class, the higher the value, the more concentrated the urine is. Now, for this test to be carried out, there needs to be at least 20 ml of urine sample that will be sent to the laboratory. And then, class, take note that the increase in volume decreases the specific gravity. Take note, the increase in volume has a tendency to decrease the specific gravity. Because again, once there is increase in volume, your urine tends to become concentrated or diluted. Increase in volume would be equivalent towards dilution of your urine. Hence, urine-specific gravity tends to be decreased. Now, there is a question. What do you think is more reliable? Will it be the serum gravity, will it be the specific gravity or the urine osmolality? Between the two, the more reliable is your urine osmolality because your specific gravity class is easily affected by the increased glucose or protein in the urine. If there is increase of glucose or protein in the urine, there is also a tendency that there will be an increase in the fluid or there will be a falsely elevated specific gravity. Again, increase or presence of glucose in the urine might lead to increase in urine-specific gravity, false elevation. That's why it's not reliable compared to your urine osmolality. Now, BUN, your blood urea nitrogen. Okay, basically, it measures the amount of urea in the blood. And what is urea? Urea is the end product of the metabolism of protein. It's the end product of the metabolism of protein. Okay, so this is affected by your muscle mass and then your dietary intake. Okay, what are the factors that may possibly affect the increase in your BUN? Take note, class, that your BUN is a very good parameter or is a parameter in your kidney functioning. So once there is a decrease in your kidney functioning, BUN tends to be increased. When there is GI bleeding, class, BUN also increase. Why? In bleed class, hemoglobin is also being damaged. Hemoglobin is also a protein. Hence, your BUN is also expected to be increased. Dehydration could be one. Another factor is increased protein intake, then your fever, and then your sepsis. So these factors can affect your BUN. Take note, try to memorize by heart that the normal BUN value is playing at 10 to 20 milligram per DL or 3.6 to 7.2 millimole per liter. Okay, take note of that. Now, BUN could also be decreased in some diseases. Examples of this are your end-stage liver disease. You might have your patients who are having minimal okay, minimal protein intake. And then you may also have your patients who have had starvation, okay, your patient who had been fasting for long, and then any condition that might result to the expansion of your fluid volume, such as your pregnancy. Okay, so class, basically your BUN could also be used to evaluate for the protein intake of your patient. Next, you have your, okay, these are the factors that I have mentioned. Again, factors affecting BUN, urine output, renal function, GI bleeding, dehydration, increase of protein, and then fever and sepsis. So these factors can increase your BUN. On the other hand, your ESLD, your end-stage liver disease, low protein diet, starvation, and fluid volume excess or expansion, such as in pregnancy, can decrease your BUN. Now, creatinine. Creatinine is also an end product of muscle metabolism. Okay, so the normal value of your creatinine is playing at 0.7 to 1.4 or 62 to 124 millimole per liter. Class, if you would look at this for the value of your BUN, okay, and for the value of your creatinine, it will be wise for you to memorize only the first value. Okay, for example, BUN, that is 10 to 20 milligram per deciliter. So class, if you can see, 10 times 2 is 20. Here in creatinine, 0.7, 0.7 to 1.4, 62 to 124. Okay, so your creatinine would also be increased if there is damage in the kidney. Okay, this is a good indication. So if you will be asked what is a better indicator of renal function between the BUN and creatinine, the best answer will be your creatinine. So class, an increase in your creatinine is also the basis why we send patients to dialysis. Okay, if there is an abrupt increase of creatinine. So this also indicates, class, the functioning of your kidney. Now, hematocrit. When I talk about hematocrit, class, this is volume percentage of red blood cells. Red blood cells, you know that it is erythrocytes. Okay? So, class, in this case, for men, the normal value is 42 to 54%. For women, class, it is 35% to 47%. Class, if I would look at this, if this is your plasma, for example, the yellow that I'm drawing there on the right side, class, and then these are your red blood cells, okay? These are your red blood cells, okay? For example, that's the normal hematocrit. Class, the hematocrit would be increased if there will be a lot of red blood cells present there, okay? Meaning, your hematocrit measures the concentration of your RBC in your blood. Okay, or you're in your plasma. So class, if there are a lot of RBC there, your hematocrit would be increased. Now, it says here dehydration. So class, what happens? Assume, class, that this is initially the body fluid of your patient. Okay, I'm referring to the drawing in your left. Now class, if these are the RBCs of your patient, okay, you can say that that is, for example, the normal hematocrit. By the time that my patient would have dehydration, class, okay, dehydration, meaning there will be a decrease in the fluids. So class, once the fluid will be decreased, okay, look at this small square that I'm drawing here, class. Okay, once the fluid will be decreased, class, it would appear that the blood would become more concentrated. That's why, class, dehydration leads to increase of your hematocrit. Polycythemia. When I talk about polycythemia, class, just think of a condition of an abnormal production of red blood cells. There is an abnormal increase in the production of your red blood cells. So because of this, class, there will also be an increase in your hematocrit. Decrease of your hematocrit is obviously brought about by, okay, let's have a drawing here. Okay, so your decrease of hematocrit is brought about by overhydration. So initially, class, if this is the plasma component of your patient, the fluid component of your patient, and then these are the red blood cells, if I will add more water to that, class, it would appear that the blood became less concentrated. Okay, meaning overhydration could lead to the decrease of your hematocrit. On the other hand, class, okay, on the top right, if this is the normal, okay, hematocrit for our patient, for example, and then there is suddenly anemia. Anemia is the decrease of your red blood cells. Okay, so if I will erase their, class, okay, the concentration of your red blood cells have been decreased in relation to the plasma volume. So meaning class, it can decrease your hematocrit. So again, just think that your hematocrit is a measure of concentration. Next, urine sodium. So your urine sodium is both affected by your sodium intake and fluid volume. Take note, class, that increase in sodium intake would also lead to increase in excretion. So don't just say that all of the salt that you're taking will stay in your body. If ever you're increasing the intake of your salt, the urine sodium in your salt, the urine sodium in your urine obviously would also be increased. So the normal value, class, for your urine sodium is 75 to 200 milliequivalents. So class, this is used for the diagnosis of hyponatremia and acute kidney injury. So random specimen, class, you need to know, usually contains more than 40 mg per liters of sodium. Okay? Next, what are the homeostatic mechanisms? So class, take note that homeostasis operates based on positive and negative feedback. What do I mean by positive and negative feedback mechanism? If there is a decrease on something, let's say your water, your homeostatic mechanisms will try its best to increase the water that is present in our body. Once the ceiling level have been reached, class, another mechanism would try to control it to maintain balance. And class, that mechanism which is involved on lowering down something is what you call your negative feedback mechanism. Okay, so there is an equation that our body is trying to perform to have homeostasis. Now, kidney. As mentioned earlier, your kidney is able to filter 180 liters of plasma every day. Adult is expected to excrete 1 to 2 liters of urine every day. Now, what are the major kidney functions that you might want to remember? Okay, it excretes your urine. It is both acting autonomously in response to blood-borne messengers such as your aldosterone and anti-diuretic hormone. Now, let's talk about the anti-diuretic hormone. So again, I mentioned earlier when I talk about anti-diuretic hormone, it tries to hold water. Okay, by the time that it tries to hold water, class, there will be decrease of urine output. And class, this holding of water will be done by your kidney. Okay, so your ADH would signal the kidney to hold water. Okay, we'll be talking about aldosterone later. Heart and blood vessel functions. Okay, so class, for your heart and your blood vessel, of course, your heart is the one that is pumping, okay, your blood throughout your body, and then the pumping action failure interferes with your renal perfusion. What do we mean by that, class? No? If there is any problem on the pumping capability of our heart, our kidney will receive the signal. Once, class, the kidney will say, oops, there is minimal blood that is reaching me. Your kidney will institute measures in such a way that the blood volume will be increased. Because, class, by the time that there is minimal perfusion to the kidney will think that there is decreased blood volume. That is why, class, it will initiate mechanisms to increase blood volume. That would include holding on to water. That might include releasing erythropoietin, okay, to increase the blood or the red blood cells. Remember, erythropoietin is produced by your kidney and tells the bone marrow to produce your red blood cells. Okay, take note of that. Now, lung function. Your lung, class, as I have mentioned earlier, is also contributory to insensible water losses. So, class, it is contributory to insensible water losses. Exhalation alone, class, could remove approximately 300 ml of water from our patient. That's why you need to be mindful, class, if your patient is having hyperpnea. When I say hyperpnea, hyper is increase, hyper in breathing. There is increase in breathing, continuous coughing, and even, class, mechanical ventilation. Okay? So, class, if your patient is having hyperpnea and continuous coughing, the tendency is there will be more fluid that is going out of your patient. So the risk is fluid volume deficit for your patient. Also, class, we will learn later on that your lung function is very significant on the acid-base balance. Your lung function is highly significant in acid-base balance. You will know later on that there are conditions referred to as respiratory acidosis and respiratory alkalosis. You also need to know, class, that your carbon dioxide, if it stays within our body, is considered to be an acidic substance. That's why, class, your carbon dioxide excreted to your lungs. For that, class, your lung has a very significant function on your acid-base balance. Next, your pituitary gland. So class, remember, your pituitary gland is the one that releases your anti-diuretic hormone. Okay, your anti-diuretic hormone, class, just be mindful, it is manufactured in your hypothalamus. It is stored in your posterior pituitary gland. Okay, take note, class, your posterior pituitary gland is also referred to as your neurohypophysis. Okay, your anterior pituitary gland is referred to as adenohypophysis. So again, neurohypophysis for posterior pituitary gland. Now, class, the main function of your ADH is to include the retention of water. As I have several times mentioned, class, anti-diuretic. It does not make you pee, it retains water. Now, class, let's talk about the adrenal function. If you can recall the location of your adrenal gland, it is located above your kidney. Now, your adrenal gland is responsible for the production of your aldosterone. So when I say aldosterone, it is considered to be a mineralocorticoid which is produced in zona glomerulosa. Your zona glomerulosa is the outer zone of your adrenal cortex. Class, to understand the role of aldosterone, just think that your aldosterone causes sodium retention and water retention. Okay? Compared to your anti-diuretic hormone, class, the difference between your aldosterone and your anti-diuretic hormone is that your anti-diuretic hormone causes water retention. On the other hand, your aldosterone causes sodium and water retention. Nadagdag si sodium, class. Okay? Now, when I talk about increasing of aldosterone, class, once aldosterone is increased, sodium will be held by the kidney, sodium will be maintained or retained by the kidney, and because of the sodium retention, class, water retention would occur. Hence, there is decrease of loss. Okay? Take note of that. In other words, class, decreased secretion of your aldosterone would cause sodium and water loss. Okay? Inverse of this diagram or of this figure or of this illustration here, okay, the inverse of which will say that decrease of aldosterone would result to sodium and water loss. Okay? Now, you need to think of the relationship between sodium and potassium for you to understand the effect of aldosterone to potassium. Class, just think that sodium and potassium are enemies. Okay? Whenever sodium is high, potassium will be low. Meaning, class, if there is too much aldosterone, there will be too much sodium retention. And the effect will be potassium excretion by potassium because sodium will prevail. On the other hand, class, if there is decrease of aldosterone, there will be decrease of sodium. Because of this decrease of sodium, there will be potassium retention. Okay, I hope you get the concept. Now, cortisol. Class, cortisol is also a mineralocorticoid. However, its effect is not very strong. Okay, it can also cause sodium and fluid retention. However, the effect is not strong unless it is given in large quantities, such as your corticosteroids therapy. So class, that's why your patient on steroid therapy would have fluid retention because your cortisol in large quantities could cause sodium and fluid retention. Other than that, you also have your parathyroid hormone. Class, the picture there demonstrates the palpation of your thyroid gland. It's just to remind you that your parathyroid hormone is closely located to your thyroid gland. Your parathyroid function or your parathyroid gland, class, excretes your parathyroid hormone. And your parathyroid hormone, class, is responsible to regulate blood calcium levels and phosphate levels. It is wise for you, class, to understand that calcium and phosphate are also enemies. Meaning whenever calcium would increase, phosphate would decrease. Class, your parathyroid hormone affects bone reabsorption. Okay? And then it also affects calcium absorption from the intestines. Class, the role of your parathyroid hormone, or let's say, your parathormone class is being excreted in the blood once there is decrease of blood calcium levels. Okay? Once the blood calcium levels are decreased, your parathormone will be excreted. And then the role of your parathormone is to increase these calcium levels. How would it increase calcium levels, class? One way is to ensure calcium absorption from the intestines. Okay? It will be getting calcium from the intestines to increase calcium. And then another is calcium reabsorption from the renal tubules. Okay? Because remember, the role there of your tubules, class, will be to excrete some of these components. However, when PTH will be high, PTH is saying, oops, calcium is very low. I need to increase it. How would I increase it? Tell the renal tubules to reabsorb those calcium that your renal tubules are about to excrete. To understand further your parathyroid hormone, try to look at this diagram. Whenever, class, the blood calcium levels is decreased, PTH will be increased. And there will be, class, demineralization of the bone, along with the absorption of the intestine, reabsorption of the renal tubules. These three things happen. So, class, what happens? Remember that bone is the storage of your calcium. There will be demineralization of the bone, meaning the bone will try to break down using the cell that we call osteoclast to release calcium to the bloodstream. Okay? That's why, class, your PTH is a friend to serum calcium level. However, your PTH is an enemy to your bone. Prolonged increase on the PTH capability, class, or prolonged increase on PTH levels, class, would continuously lead to demineralization of your bone. Not helpful to your bone if it will continue. Okay? Now, going back, again, there is decrease of blood calcium levels. Because of the decrease of the blood calcium levels, PTH will be there. Okay? It will help. It will increase your calcium. Now, that PTH will try to reabsorb from the intestine, absorb from the intestine, reabsorb from the tubules, and then demineralize the bone. Once these three things happen, it will increase calcium levels. Once calcium levels have reached normal, calcitonin will be released. And calcitonin will say, okay, let's stop those three things because calcium is already normal. Class, this is what we refer to as your negative feedback mechanism. Once everything is going up, okay, a control mechanism will be instituted by your body, referred to as your negative feedback mechanism. The next function that we need to understand are your baroreceptors. So, class, baroreceptors. When I talk about barometer in your basic sciences, baro means pressure. Okay, baroreceptors. So, meaning it measures or it responds to pressure. Class, your baroreceptors are located in your left atrium and carotid in the aortic area. So, you have your aortic baroreceptor found here, there, and then you also have your carotid baroreceptor. Now, class, these baroreceptors respond to changes in the circulating blood volume, and they can regulate your sympathetic nervous system and your parasympathetic nervous system. For us to simply recall sympa and para, just take note that your sympathetic nervous system, what happens to your heart rate? Increase or decrease? It will be increased. What happens to your blood pressure? In sympathetic nervous system, it will also be increased. Okay? Just take note of that. So if sympa response is being stimulated, your heart rate and your blood pressure are expected to increase. Obviously, the opposite will be happening if your parasympathetic nervous system will be stimulated. To understand baroreceptors, let's look at these 9 boxes here. Now, class, anytime that there is decrease of arterial pressure, okay, if there is decrease of arterial pressure, meaning there will be fewer impulses from the baroreceptors. So, class, what are the reasons of decrease of arterial pressure? It may be blood loss. Okay, it may be failure of the heart to pump properly. So once there is decrease in this arterial pressure class, there will be fewer impulses from the baroreceptors. The baroreceptors will be saying, oh, I'm receiving minimal pressure. What might be happening? So your baroreceptor will stimulate your sympathetic nervous system. It will inhibit your parasympathetic nervous system. Once your SNS class is stimulated, heart rate would increase. And then there will be constriction of your renal arterioles. Because remember, one effect class of your sympathetic nervous system is vasoconstriction. And because of that constriction of renal arterioles, what happens to the blood flow going to the kidney? The kidney's blood flow will be decreased. And the kidney will perceive that there is minimal or there is decreased blood volume. Because of this decrease in blood volume, aldosterone would kick in. And when I say aldosterone, what is the effect of aldosterone again? It causes sodium and water retention. Okay? After that, there will be a decrease on glomerular filtration. When I say class glomerulus, just remember it is the basic unit of your kidney. So whenever glomerular filtration class is decreased, meaning minimal amount of fluid will be excreted. Meaning there is an increase in your water reabsorption, along with the increase in your sodium and water reabsorption. So class, overall, the effect is once there is decrease in pressure on the arteries, your baroreceptors will trigger other parts of the body to increase this pressure. And your baroreceptors are doing it by increasing your fluid volume. Okay, recall that. Now, you also have your renin-angiotensin aldosterone system. Interesting work. Okay, class? RAS. We refer to this one as your RAS. Now, class, whenever there is decrease of renal perfusion, other than calling on aldosterone, anti-diuretic hormone, you also have your RAS. Okay? Class, your RAS is also triggered by decrease in the renal perfusion. Okay? Class, once there is decrease in renal perfusion, renin would be released. And the purpose of this renin is to convert angiotensinogen, which is found in your liver, to angiotensin 1. Okay? Again, renin catalyzes the conversion of angiotensinogen in the liver, okay, to angiotensin 1. And then class, you have your friend there, your ACE, your ACE or your angiotensin converting enzymes. Your angiotensin converting enzyme would convert angiotensin 1 to angiotensin 2. Angiotensin 2 class, you write in your note, is a potent vasoconstrictor. It's a potent vasoconstrictor. Class, this process of converting angiotensin 1 to angiotensin 2 takes place in your lungs. Takes place in your lungs. Now, since vasoconstriction occurs, you know the sequela. You know what would happen? Blood pressure would be up. Thirst mechanism would be triggered because vasoconstriction. Okay, then you would have sympathetic nervous system stimulation. Once sympa is stimulated, aldosterone will be stimulated. And once aldosterone is stimulated, there will be retention of sodium and water. Just think of that. And once sodium is retained, class, what happens to potassium? Potassium would be decreased. Okay? Potassium would be decreased. Sodium is high, potassium will be low. So this is your RAS. Another concept here that you can connect to pharmacology is your ACE inhibitors. If you can recall, class, ACE inhibitors, it is a classification of your antihypertensive medication. So class, it says ACE inhibitor, meaning class, it prevents. These drugs, ACE inhibitors, prevents the conversion of angiotensin 1 to angiotensin 2. That's why your ACE inhibitors can decrease your blood pressure. Kay class, it is angiotensin 2 which is considered to be a potent vasoconstrictor. Now, ADH and thirst. So you have your anti-diuretic hormone and thirst. Class, whenever serum concentration and osmolality would be increased, again, serum concentration and osmolality is increased. What do you think happened? Is that dehydration or overhydration? That is dehydration. Okay? Remember class, na-dehydrate, nagtaas ang concentration sa blood. So whenever class serum concentration and osmolality is increased and blood volume is decreased, hypothalamus will be stimulated. And hypothalamus would produce your ADH, Anti-Diuretic Hormone. And your anti-diuretic hormone would travel to your pituitary gland. Pituitary gland would release this. Okay? And part of the effect of your anti-diuretic hormone, okay, is to stimulate thirst. Okay, stimulate thirst. Oops, uhaw ako. I feel dehydrated. Okay, that's why you drink a lot of fluids, triggered by your ADH. Let's talk about your osmoreceptors. Class, your osmoreceptors are located on the surface of the hypothalamus, and your osmoreceptors are capable of detecting changes in your sodium concentration. Whenever, class, there is a decrease in your sodium concentration, your neurons become dehydrated, and then it would release an impulse, class, towards your pituitary gland and tells your pituitary gland to increase the release of your ADH, okay, of your anti-diuretic hormone. By the time, class, that the normal volume of the blood would come back or return, your osmoreceptors will be able to detect that, and then once it detects normal fluid volume, the feedback to the osmoreceptors to inhibit further ADH production would be released. Okay? So basically, the purpose of your osmoreceptor is to detect changes in sodium concentration. Once there is a change, it will trigger for the release of your ADH. And then, class, once ADH is released and once blood levels are normalized, your osmoreceptors would halt its function. Then you have the term natriuretic peptides. Class, there are several natriuretic peptides. You have your ANP, BNP, CNP, and DNP. Class, your natriuretic peptides are capable of natriuresis. Natriuresis. Natrio for your sodium and uresis for excretion. Also, class, it can cause direct vasodilation. And your natriuretic peptide is an opposition to your RAS. Okay? It opposes your renin-angiotensin aldosterone system. So, class, your natriuretic peptide, as I've mentioned, are of several types. So, you have ANP, BNP, CNP, and DNP. Our attention is focused on ANP. ANP is atrial natriuretic peptide. Okay? Class, your atrial natriuretic peptide can be found in the atrium with myocardium or atrium-myocardium with distribution on the atria and the ventricles. Class, your ANP is released, okay, and its effect will be the decrease of your blood pressure. Okay? It decreases your blood pressure. Because remember, class, it is the opposite of your RAS. So meaning the effect is, if RAS, class, would try to increase water, this time, class, your atrial natriuretic peptide would try to decrease water. It would try to decrease sodium. Okay? Meaning blood pressure would be decreased. The normal value of which, class, is playing at 20 to 77 picograms per ml. Okay? Or nanograms, I mean, per ml. Okay? Now, it is increased in conditions such as acute heart failure. Okay, class, when I say heart failure, meaning the compensatory mechanisms of your heart are failing. Paroxysmal, SVT, supraventricular tachycardia. So, class, in supraventricular tachycardia, there is excessive activity of your ventricles. Okay, your SVT, if you can recall in our BLS, is among the dysrhythmias that can lead to cardiac arrest. Other than that, this is also common in hyperthyroidism. Also common among patients with SAH or subarachnoid hemorrhage. And then you have small cell lung carcinoma. Okay? Other types, class, are your BNP, brain natriuretic peptide, which by which parts of which can be found in your heart and then in the brain. It's distributed in the brain. And then you have your CNP and DNP. It's wise for you, class, to note that increases on ANP and BNP are caused by volume expansion, such as your exercise and pregnancy. You also have calorie restriction, hypoxia, and an increase in the cardiac feeling response. So this is how your natriuretic peptides work. Now, gerontologic considerations. Among our patients, class, who are having fluid and electrolyte problems, the most at risk, class, are your gerontologic population. Why? There is decrease in cardiac function, decrease in renal function, and even in respiratory function among our gerontologic patients. There is also decrease in muscle mass, meaning, class, any problem when it comes to fluids and electrolytes might have a grave effect, on them compared to their younger counterparts. Other than that, class, high normal and minimally elevated serum creatinine could already indicate substantially reduced renal function. Okay, so for example, you will not be saying, oh, the release is just minimal. No, we do not underestimate the increased, class, because minimal elevation of creatinine among your old patients may already be an indication of substantially reduced renal function. They also have a lower concentration of body fluid, meaning they are at risk for dehydration. Also, class, you need to consider that if these patients will be having laxatives, class, or enema before colon X-ray studies, for example, okay, just remember, when I say laxative and enema, what do? They would irritate your bowel. They are intended to clean your bowel. However, the risk is dehydration. And if I am talking about our gerontologic patients, class, this risk for dehydration needs to be addressed. Okay? In cases like laxatives and enema are really needed, class, you need to prepare an intravenous fluid, just in case the patient would have dehydration. Now, subtle or atypical signs and symptoms of fluid volume problems may occur among these patients. What do you mean by that? Okay, some of them may only have slight hyperthermia. Some of them may only have minimal tachycardia, okay, or borderline tachycardia. Whereas these may already indicate that they're having severe signs and symptoms. Others may manifest with delirium. Now, fluid volume excess risk, class. Okay, class, they might have the risk of fluid volume excess secondary to excessive volume of IV fluids. That's why if you have geriatric patients, especially if they have cardiac function or cardiac problems, class, your IV fluid that will be used should be in a microset that will allow for proper regulation of your IV fluid and prevent rapid administration of your IV fluid, reducing the risk for fluid volume excess. They're also at risk, class, of fluid overload and even your cardiac failure. Other than that, you need to remember that their kidney mass is also decreased. Glomerular filtration rate, class, is also decreased. Blood flow to the kidney is also decreased. Their ability to concentrate urine becomes poor. They have a tendency to have lower sodium. And then, because of that, there is increase in serum potassium and they have decrease of your subcutaneous tissue. Class, thank you very much for your kind attention. I would expect that you will be reading our reference text and you'll be attending our live session for us to augment this discussion. Once again, God bless in your studies.